Good morning, and thank you for joining the New England Nursing Home Quality Care Collaborative. Today's webinar, Achieving the Triple Aim for a Triple Challenge, will focus on pain, weight loss, and incontinence. My name is Sarah Drenick, and I'm going to quickly review some housekeeping items before we introduce today's speaker, Dr. Lynn McNicoll. This webinar will be recorded, and the presentation will be available within a few business days. The phone lines will be on mute for the duration of the presentation. We ask that you please do not put your line on hold. If you have a question at any point throughout the presentation, please enter it in the chat panel to the right of your screen. Please make sure to send your comments to all participants, as we will be monitoring and responding to your questions and comments in chat. We will also have time for questions at the end of the presentation. Anything that we do not have time to get to today will be answered during part 2 of this webinar, which will take place on February 9th at 11. Lastly, if you find that the presentation is a little cut off, please use the plus or minus icons at the top right of the presentation window to adjust your screen accordingly.
Sarah, you can use the page up or page down buttons on your keyboard or the arrows at the top of your screen to advance. There you go.
Thanks, Morgan. Again, I want to thank you for being part of the New England Nursing Home Quality Care Collaborative. 660 nursing homes across New England are participating in the collaborative, focusing on quality improvement. We know that an educated and informed staff is the key to success, so we want you to take a look at what's coming up. Our first Affinity Crawl series for 2017 kicked off last week. The first group focuses on antipsychotic medication reduction, and we had a great turnout. Each group is it's a 4-part series. The overall goal for each series is to provide you with education and support around quality improvement strategies to ultimately improve that particular QM and its impact on your 5-star quality rating. Facilities who fully participate in any of these series will be adding to their QHI programs, learn what other facilities in New England are doing, and receive supportive activities each month to help their efforts directly impact the residents' outcomes. We have subject matter experts on each call to present and answer your questions, so keep a lookout for upcoming affinity group invites for you to join. The virtual educational webinars, like the one today, will continue quarterly throughout the year on various topics. Each of these educational sessions includes a 2-week follow-up session to hear from facilities throughout the region. Today's session will have a follow-up on February 6th. It will be on February 9th. In April, we will highlight the phases of the final rule and timeline, as well as actions that you can help implement to support it. So in summary, the Affinity series is for people who are interested in improving a specific QM, and it is a 4-part series with actions between each monthly call. The virtual educational webinars are quarterly on a topic usually of high interest to most facilities, and includes a 1 follow-up session to allow the facilities to share what they're doing as well as barriers. We always have at least 1 nursing home who presents to share best practices and to take you along their journey of success. Now let's get underway with today's presentation. I'm happy to introduce Dr. Lynn McNicoll, who has been a consultative member of the QIN-QIO team for years and is a geriatrician by trade, practicing in both long-term care centers as well as in hospitals. Thank you for joining us today, Lynn.
Lynn, don't forget to press #6 on your line so that we can hear you.
Can you hear me now?
Yes, we can.
Okay, great. Thank you so much. Welcome, everyone, and good morning. Thank you for joining us today. I truly apologize for canceling off on you 2 weeks ago. I was one of the victims of the viruses that have been percolating in our state of Rhode Island among all of our facilities. But today I'm happy to present to you how the geriatrician's approach of how we try to target pain, weight loss, and incontinence, and try to relay to you my approach to dealing with these problems, and hopefully that will help you guide you and give you some comfort in trying to tackle these three difficult problems. Let's see. Okay. So we are all practicing in the nursing home. It's a very complex and complicated interaction with families. And I'm lucky enough that at Steerhouse Nursing Home, we are blessed to have Oscar the cat. If you don't know about Oscar the cat, you might want to look up his Wikipedia page. He is an extraordinary cat that provides end-of-life care for our patients. And for me, he's a geriatric cat because he really, truly views our residents and provides resident-centered care. Please look him up if you don't know about him, and I hope you can have somebody like Oscar to provide end-of-life care in your advanced dementia units. Today we're going to talk about nursing homes consistently having to deal with pain, weight loss, and incontinence as very challenging issues. They might seem like simple enough, but they do require individualized, multi-pronged, team-based approach, which is much harder to implement than said. And these are truly classic geriatric syndromes, and I hope to try to help you figure out how to incorporate some of the principles of geriatric care into your systematic quality improvement approach. So we'll define geriatric syndromes, we'll describe how to approach some of these geriatric syndromes, and hopefully you'll come out of this with some strategies. I'd also like to mention just recently Atul Gawande came out with a great article called The Heroism of Incremental Care. If you haven't read it, it's a great New York Times article which really emphasizes some of the approach of geriatric medicine and geriatric care that we all provide in the nursing home, and really highlights how complicated and difficult and stepwise that we have to be, and patient, and all of us have to demonstrate that patience in tackling, and that this is sort of the underlying principle for a lot of what we do in geriatrics and in nursing home care. It also highlights well with the triple aim, which I'm not sure if that's going to stay as a mainstay of CMS, but it is something that we all strive for to improve the patient experience, to achieve better health outcomes, and hopefully manage or reduce costs as we're doing that. I'd also like to add the fourth aim, which is improving clinician experience, which has been suggested. If we can do all of that while making sure that our nurses and physicians and activity folks and administrators are all enjoying the quality of the work that they're giving and satisfied in their job, then we can also improve our staff stability across the board. So there are several reasons why these metrics are important. They are affected by our regulatory folks. The surveyors are obligated to evaluate these when they come by. They also might impact us financially because they do affect our MDS quality metrics and our 5-star rating. Only one of those three, the pain, is actually in the 5-star rating, but that might change in the future. We don't know yet. And of course, we're all strive to provide person-centered care, and ultimately, I think that's our goal, to improve the quality of life and if possible, as well, the length of life of our residents. So let's start a bit with the regulatory needs. I'm not an expert in the regulatory, so please bear with me as I try to explain some of this, but my understanding is that CMS instructs surveyors to use the F309 to determine deficient care in dementia patients and residents because there is no specific investigative protocol for the care of the resident with dementia. And this one states that each resident must receive and the facility must provide the necessary care and services to attain and maintain the highest practicable physical and psychosocial well-being in accordance with the comprehensive assessment and plan of care. And I'd like to highlight that this is the comprehensive assessment and plan of care is really what's key here. And so what they've been instructed is that any approach must be based on a careful, detailed assessment of both physical, psychological, and behavioral symptoms, and underlying causes as well as situational and environmental reasons of behavior. That really means that, if there's something that's not going well, whether it's pain or incontinence or weight loss, that it's expected that the facility will do a full comprehensive evaluation. It's difficult for us to understand or know exactly what that means, especially there are variations from state to state. For example, in Rhode Island, our state surveyor came by and said, well, if somebody is on an antipsychotic and we don't think it's justified, we will give you an F-tag violation. However, if a resident has a poor quality of life and is in psychological distress and we feel that they should have been on an antipsychotic, we are going to give you a violation at that point. So it's, you're damned if you do and damned if you don't. Your approach might be what you interpret that, but the way that I would interpret that is if we're doing the right care, if we're doing as best we can, if we've done a comprehensive evaluation, if we're doing all the right things for the person, and we justify it and we document it, then we've done the right things for the person, but we've also done the right thing from a regulatory standpoint. And I think, even though it's vague, that provides us with sort of a leeway to justify the care that we're providing, as long as we're doing it in a comprehensive and thoughtful approach. And that's what I strive for in general. That's what I've always tried to achieve in my care as a medical director or as a geriatrician in my nursing home. So next I'd like to just highlight some of the statistics, some of the data that we have for these three measures. You all know that they're all in the composite score for the 11th scope of work. So this is data from the recruited homes for the regional QIO, and as you can see, Vermont has done a remarkable job in improving their rates. Rhode Island, Connecticut, Massachusetts, and New Hampshire are all below the national average. But, even Rhode Island, even though we were low, we haven't really made any improvements, so we need to keep working at it. And if you were to look at your quality metrics that have the most impact on a nursing home, on your nursing home, this is an example of a nursing home, you might want to evaluate which of the metrics are impacting negatively on the composite score. And I'm willing to bet that incontinence, weight loss, and pain are probably some of the highest top 5 or 6 of your quality metrics negatively impacting your composite score. And that's primarily why we wanted to talk about these metrics today, to see how can we focus on these 3 metrics. For the moderate to severe pain, these are the regional data for New England, and I would like to highlight that Massachusetts and Connecticut are both below the U.S. national average, so we should all strive to reach that level. We've had a decline in weight loss across the board, generally, for all of our states. But again, Massachusetts and Rhode Island, as well as New Hampshire, are below the national average and should be congratulated. And then for incontinence and for bowel or bladder, the numbers are much higher. We're talking about in the 50s, 40s, and 50s, as well as 60s. Again, Rhode Island, Connecticut, and New Hampshire are below average, but they seem to all be going up, so not sure they're trending upwards. So we still have some room to improve on that. I'd like to just highlight a bit to remind people briefly about the basics of the 5-star rating, which you're probably more familiar than I am, but in case you don't, remember that step 1 starts with the health inspection rating and gives you a star rating based on that. Step 2, you add 1 star to the step 1 if the quality metric star rating is a 4 or 5, and I think it's based on 16 quality metrics. But you would subtract 1 star if the staffing rating is only 1 star. And then step 3, you would add 1 star only if the quality metric rating is 5 stars. I'm sorry, this is the 16 metrics that are in this rating, but you would subtract 1 star if the quality measure rating is only 1 star. So you could start at 3 and go down and end up with 1, or you could start at 3 and go up and end up at 5. Hopefully. So, as a geriatrician, I think we all understand that geriatrics is complicated. The care of our residents is very complicated. But trying to piece it all together is very important. And the way that I view it in my mind is that the best geriatricians and the best people who do geriatric care are able to look at all the details in this word salad in particular, but also be able to look at the global picture. So you sort of have this double vision of detail-focused, but also globally, and being able to integrate those two together at the same time while you're managing your residents. That's a skill that we all need. And let me just talk a bit about geriatric syndromes. I'm sure you might have all heard about this, but I'm just going to review it briefly. The idea being that pain might not just be arthritis as a cause, it might have multiple contributors. So it's a multifactorial syndrome. And so you might have depression, arthritis, and maybe it's just boredom contributing to pain. And so when you want to target pain, you just don't want to give Tylenol and that will be it. You might want to give Tylenol, but you might want to do other programs that will improve the mood and the boredom as well. And the good thing about many of these geriatric syndromes is that many of the targeted interventions for one geriatric syndrome might be the same for another geriatric syndrome. So if I were to target pain, I might do the same things if I wanted to target weight loss. I might do standing pain medications, music and memory, and improved activities on the unit, which would help with both of those geriatric syndromes at the same time. And so the way that I view geriatric care for my residents and my patients overall is that these are the risk factors on the left-hand side that they might all have that might contribute to a problem or a geriatric syndrome. But many of them overlap and interact to contribute to many of the geriatric syndromes. So a lot of our residents might have many of these problems in the first place together. So if we took care of all the risk factors and approached it globally, we might improve the geriatric syndromes, and then we might improve the long-term outcomes as well, which we talked about in terms of poor quality, reduced life expectancy, poor satisfaction of the residents, the family, and the staff. So that's how I approach the care. And I'd like to mention habilitation therapy. If you haven't heard about it, I would look it up. Paul Ria and his groups have done a great job with this program, which really focuses on optimizing and extending what is possible now, not what is possible in the past for each person, and creating an environment that is safe and healthy for each individual. It's a whole several-day course. If you haven't done it, I would highly recommend looking into it. These are some of their outcomes. They looked at number of altercations. This was recently published. And if you look at resident on resident or resident on staff altercations, those all, especially the resident on staff altercations, came down with the intervention. And then we also looked at anxiety, hypnotics came down, antipsychotic medications came down, behavioral symptoms came down, falls with major injury, as well as resident on staff altercations. So something to consider, I think, as you move forward. But the reason I also like it is that it does provide a geriatric holistic approach of individualized, multifactorial, person-centered care. And I'm going to repeat this again, but if you do that, you're not only going to provide good care, but you're going to improve on your metrics, and it's ultimately the right thing to do. But of course, if you don't document properly, you'll be at the whim of the surveyors. And so you need to be able to document the care and the plan that you're providing well. So let's talk a bit about each of the three metrics. Of course, I could probably give a full-day course on each of these, and this is a 45-minute webinar. So I'm going to try to highlight some of the key points as a geriatrician for each of these metrics that I find might help. So as you know, pain in the nursing home is quite common. 10% of long-stay residents have moderate to severe, which is what the metric is focusing on. It's almost always arthritic, meaning musculoskeletal, but don't forget that there might be a neuropathic component. So even if you give Tylenol, that's not going to affect the neuropathic component. It might not be able to eliminate the pain, so you might want to try to focus on reduction strategies rather than elimination strategies, and helping the resident and the family to adjust their expectations as well. That also goes to how people are rating or evaluating their own pain scores. It's often needs an individualized approach, but also a multimodality approach. So medications might not be the only strategy. Physical therapy, music, ice, heat, positioning, all of those things might help for managing the pain and reducing it from a moderate to severe to a mild pain. Of course, the care plan needs to be completed and followed, which is one of the major key points from the surveyors. And, of course, engage your entire multidisciplinary team. And these, as you're well aware, some of these pain scales, I prefer the facial ones. I think as we age, as the generations age, we might end up with different face scales, and when the millennials are old, they're going to end up with Lego face scales. That'll be my son's face scale. But in dementia, it's particularly difficult to assess pain. And sometimes it's just by observation. You can see that they're uncomfortable, or they're holding a joint, or they're moaning, or they really don't want you touching a part of their body. So that's pain behavior symptoms. So you might want to consider pre-medication prior to care, standing medications, avoiding pain-inducing movement. So if being in the shower is a problem, then you might do a bedside wash or a bed wash. And then reassuring. I know that a lot of people get fear of pain, so if you're going to approach them in a manner that in the past has triggered pain, you might want to alter or change the way you're approaching a person so that you reduce the fear that's related to the behavior. If behavior is potentially suggestive of pain, you're not quite sure, but it might be, then you might want to make sure that their basic comforts are being met in general. Is there another potential cause for the discomfort? Is it an infection, a urinary tract infection? Is it constipation? And then consider empiric trial of analgesics. Now, the trial is highlighted here because you don't want to just start it and forget about it. You want to do it for a period of time with an order for reassessment, and just actively monitor, and if the behavior does not change, then the trial has been either not effective or needs to be upgraded to a different agent, a higher dose, or stopped altogether. But you don't want to start something and then have them on it forever, because even Tylenol 3 times a day is not something that we want to give to somebody unless they are going to need it. Another thought is to provide language to residents about pain management so that the residents respond more accurately to the MDS coordinators when they're being surveyed. So that might be related to some of the education about pain, about their expectations about pain, and so helping them discuss their pain in a manner that would be more accurate. So let's talk a bit about weight loss. Again, a complicated problem, and it often involves multiple components. Of course, the food is something that the nursing homes can modify, although not physicians per se, but the quality of the food, the smell of the food, whether the food is being prepared in front of them or an hour or two before in some basement kitchen. Those are all factors. We all know that when we have mobile kitchens that are preparing the foods right in front of the resident, the smell of food, the preparation are all increasing appetite, and they get anticipatory hunger, and so they might eat better and not lose weight. So many of our institutions have managed to figure that out, how to do that, and I think that that's a huge issue. The type of food, I have a resident right now who is Portuguese, and she doesn't like most of the meals, unfortunately, and so we're trying to figure out strategies to get either some spices or some sauces that might change the smell or taste of the food so that she might enjoy it better. Also, the variety. There's only so much pasta and chicken that you can have. You need to make sure that there's alternative proteins, fish and meat and veal and pork, other than chicken and chicken and chicken all the time. And I think there's been a shift in special diet approaches in general. We're trying to lean away from that, unless it's absolutely necessary. And if they absolutely need to be on something, we can sometimes adjust medications rather than put them on a restrictive diet. I always look at whether chronic pain or depression might be contributing to anorexia and weight loss. Of course, every time they've had an acute illness, whether it's infection or constipation or delirium, they might eat less unintentionally from that. And then think of the medications. So that would be to engaging your physicians to review the medications. Do some of the medications alter taste? Do they cause anorexia? Are they potentially causing constipation and abdominal discomfort, which is leading to decreased PO intake? Of course, you all know that the metric is unintentional weight loss of 5% in 30 days or 10% in 180 days. And the reason that's important is because a 5% weight loss provides a 5 to 10-fold increased risk of death. And certainly if somebody is terminally ill and you've documented that in your care plan, that should not be reflected in, because it's expected that there'll be low oral intake and weight loss. If you wanted to use a tool, I really like the mini nutritional assessment. It's a cute little assessment, and it helps you with 6 points that give you a score about their risk for malnutrition, and your nutritionist might be using that in your institutions. In addition, some other nutritional interventions, of course, monitoring closely, especially somebody who's at risk, using a multidisciplinary approach. Don't forget to engage your OT for assistive devices and your speech therapist for potentially some swallowing techniques. But also the CNA, they have a lot of input. They see them much more closely and be able to tell you, oh, they don't like this or they don't like that, or they like this more salty or that with this salt. And of course the dentist, so don't forget that some of these residents are wearing dentures. If they changed at all, the dentures might be loose and makes it much more difficult for them to eat, and then they might just eat less just because it's more work. Again, review medications and work with your physicians and pharmacists as well. And then with end-stage dementia, comfort feeding is very important. So some other treatment options for weight loss, don't forget that depression can cause anorexia, but the medications for depression can cause anorexia, dry mouth, and constipation. So it's difficult to figure out which is best. If you can manage the depression and deal with it without medications, is probably the best thing. And sometimes that's just engaging the family more and having them participate in more activities, potentially even light therapy. But if you do need to start medications, of course, mirtazapine, as one of its side effects, can increase appetite. So if you've got somebody who's having trouble sleeping, has a poor appetite, and is depressed, then mirtazapine, if tolerated, would be your best agent. Oral supplements is a controversial thing. We all do it. We all sort of believe in it, but the studies have shown only minimal benefit. Excuse me. And the American Geriatric Society actually recommended against it in their Choosing Wisely campaign. I'm not 100% in agreement. I might not even be 50% in agreement with that recommendation. But if somebody is at risk for weight loss or is actually losing weight, I'm going to be all for supplementing, as long as it's not replacing. And that's the major concern from the American Geriatric Society, is that people are being supplemented and they're not eating their meals in addition to the supplements. And we wish otherwise, but Megace and Marinol have had no scientifically proven benefit, and especially in the case of Megace, lots of side effects and potentially harmful. And I'd like to start a food and memory campaign to help people get individualized food menus or taste. Let's talk a bit about incontinence. This is the up-to-date incontinence pathway, and I'm going to walk you through some of this step by step. Of course, it's very high in the nursing home, as we saw in our graphs earlier, between 40 to 65% in our region. The first thing you need to do is rule out complicated incontinence. Is there retention, first of all, which all of your nursing homes should have bladder scans. At this stage, it's an extremely useful tool to easily and safely rule out urinary retention. If there's any evidence of fistula, hematuria, or neurological signs, then you need to refer to a urologist immediately. But once most people don't have those problems, and of course also just keep in mind that men who have recurrent urinary tract infections are usually also people that would require a referral to urology, because they probably have underlying BPH. Then, once you've ruled those complicated incontinence causes, then you have to figure out what kind of incontinence is this. Now, most women, stress is a huge factor, but they might also either or have urge incontinence. So there's many women and men who might have both stress and urge incontinence. Overflow, of course, is the most worrisome one because it can cause renal failure, and that's why a bladder scan is so important. And functional, so is it from dementia, is it from arthritis, is it from a stroke, or from Parkinson's? They might not have any problem with their sphincter or their bladder, but if they can't quite make it to the bathroom in time because of their functional limitations, they might have incontinence. And that, for me, is the cause that is most easy to solve. Stress incontinence in older women, once their sphincter isn't working, it's really hard to improve on that unless they've got a prolapse, and then we can talk about that in a minute. Evaluate for potential reversible causes. So if it's a new symptom, which is usually not the case in the nursing home, but if it's a new symptom, you need to rule out urinary tract infection, side effects of medications, calcium level, hypercalcemia, diabetes out of control, constipation, so an impacted stool and the colon can cause suppression and stress incontinence. So all these potential reversible causes, and then as a general rule, prompted voiding might be beneficial, especially for stress, but also potentially for urge. There is minimal but some evidence to show that this is effective at reducing the rate of incontinence, but not necessarily eliminating it. And most trials, unfortunately, have used not real-life situations, so they're using research staff to do the prompted voiding as opposed to what happens with the usual staff that's available on a nursing unit. So it's something that requires more study before we can say that prompted voiding is an effective strategy, although I think we all try to do that in some way or fashion. An exercise program, especially in the nursing home, that has not shown consistent data to show that it works, and it's very difficult to teach. I would consider a pharmacological treatment only for urge incontinence, especially if you're sure that it's urge incontinence, and remember the differences between stress and urge. Stress incontinence is usually a small amount of urine, especially with bending over or coughing, whereas urge incontinence, you get a sudden urge to go, and then you have a huge loss of urine. So it's a much larger amount. And usually the urge incontinence happens at much smaller intervals. So people have smaller bladders, and the bladder is more irritable at smaller volumes, so they might have these incontinence episodes more frequently during the day. Remember that all of the medications for urge incontinence have anticholinergic properties. The newer ones are purportedly less likely to cross the blood-brain barrier and less likely to cause CNS side effects, but they all do to a certain extent. And the only exception might be mirabegron, which stimulates beta-3 adrenergic receptors primarily. That's their primary function, but it's also somewhat anticholinergic. So if you were to start somebody that you were fairly confident had urge incontinence, that might be the drug to try. Urodynamic studies are rarely necessary, but if you have a male with incontinence and a UTI that you're concerned, then that would be, but usually the urology, you refer this person to urology and they're going to end up doing that. And then nursing unit with a dementia unit, of course, this becomes even more difficult to evaluate and becomes even more difficult to determine whether it's urge or stress incontinence. And the algorithm kind of goes out the window a little bit. And most of even if you really thought that this was urge incontinence, the antimuscarinic agents might exacerbate the dementia. And remember that dementia residents who are on cholinesterase inhibitors, that function is to increase the cholinergic activity, and the bladder muscle, the detrusor muscle, is stimulated by cholinergic activity. So as a consequence of having somebody on a cholinesterase inhibitor like donepezil or Exelon, you're going to end up potentially exacerbating urge incontinence. There are great studies showing that for every person that starts an Aricept, a third of them will end up being on an urge incontinence medication within 3 months. So that's not something that you want to do. You don't want to give a medication to stimulate cholinergic activity and then 3 months later give them a medication that inhibits cholinergic activity. You end up with a zero-sum balance. So you might consider stopping the cholinesterase inhibitor once they're on a dementia unit, once they're stable, and see that might potentially improve your incontinence, but you have to worry about worsening agitation and weight loss, so you need to keep a close eye on that. But that is something to consider. Other treatment options for incontinence, of course, review the medications, especially diuretics. I had actually yesterday a resident complain that he would wake up often in the early morning with a large incontinence episode. It was beyond the diaper, beyond the bed sheets, it wet the entire bedding. And can't we get rid of the furosemide? And unfortunately, he's just now, 2 months after a heart failure, a severe heart failure episode, so no, we cannot get rid of the diuretic. But I looked at his scheduling, and he was getting 80 in the morning and 40 just before bed. So that didn't make much sense to me, so I moved his 40 evening dose to 2 p.m., and we'll see, perhaps we'll be able to avoid that early morning incontinence. We might not be able to get him out of our metric for incontinence, but at least we'll improve his quality of life for not waking up potentially with a bed full of urine. In advanced dementia, especially pessaries are difficult and potentially traumatic for some of these residents, so it would be only with severe prolapse where it's affecting renal function. Other options are actually just to close off the vagina opening, and so you eliminate the chance of a stage 4 prolapse without having to do manipulations in the vagina with a pessary every month or every 3 months for the rest of their lives. Surgery with a bladder pull-up is also not usually a recommendation. First of all, they don't always work, and if they do work, they don't last a lot of the time. And it might also be more traumatic than helpful for some of our residents. There's botulinum toxin, which is being injected into the detrusor muscle, into the bladder wall. That's a treatment option for urge incontinence. I have yet to see a very good study or a patient of mine who's benefited from this, and none of my nursing home residents have been a candidate for this yet. As well, there's percutaneous tibial nerve stimulation and sacral neuromodulation, which are meant to either stimulate or tone down the bladder muscle, require more than a dementia person could handle. So I think there are many solutions for improving these metrics. Some other ideas, I did a version of this talk in Maine a few months ago, or last month actually, and some of this audience came up with some of these ideas, which are great. So engaging a resident and family councils, I think that might be most useful, especially for the weight loss. What are some of the suggestions? What are some of the complaints? organize a tasting party where staff sample the food, provide feedback to the kitchen. I think that's a great idea. Sometimes I walk into a nursing home and the smell is absolutely wonderful and I'm starving and I want to eat their food and grab the plates of my residents, which I don't. But also sometimes I might walk into a nursing home and feel like heading to the bathroom and throwing up. So the smell of the food is extremely important. And there are strategies, even with pureed foods or textured foods, that might be more appealing than the blobs that we sometimes see on our plates these days. You might also want to do a deep dive into residents that trigger 2 or more of these metrics. So if they have pain and incontinence or pain and weight loss, then target those people first in your interventions rather than trying to target everybody for all the metrics. I highly recommend the Music and Memory program. I think it's a wonderful program. I'm glad to know that the nursing home that I work with is implementing this, and it's very successful. Books on tape for visually impaired, and I don't know if you've seen some of the virtual reality, but I've seen some of the nursing home residents using virtual reality, and it's fascinating. You'd think that they'd all get dizzy and faint, but they don't. They do very well with that. So my take-home message is really, if you do good geriatric care, both physician and nursing and activities and pharmacy care, everything will fall into place, really. Your survey results will improve, your metrics will improve, your 5-star rating will improve, and your staff, resident, and family satisfaction will improve. And that's it. I'm happy to have some discussion. I'm going to move this over to Sarah, I think. Am I moving this to Sarah?
Yep.
Okay. And I think Sarah Morgan will tell you guys how to unmute your lines. If this is the time for questions, or we want to wait until after.
Lynn, there is one question in the chat window, and somebody was asking, what is an EEP environment?
I saw that there's a typo. Is that from the slide that had the 3 columns? If it is, that's supposed to be sleep.
Maybe that's what they were referring to.
Yeah. But somehow that got deleted. I apologize. Okay.
Thank you. Morgan, can you tell participants how they can ask a question? Also, you can submit a question using the chat panel on the right-hand side of your screen.
So if you have a question, all you have to do is press #6 to unmute your line, and then also make sure you haven't manually muted your phone as well, and you will be able to ask your question. Again, it's #6.
We also had a question in chat on whether or not you would have access to the slides. You should have received an email this morning or yesterday reminding you of the webinar, and there should be a link to access the slides from that email.
Sarah, I'm also putting it in chat right now.
Perfect. Do we have anyone on the line to ask a question?
Or any comments or ideas, that would be great.
Sarah, we had somebody asking about a scale that Lynn had referred to. I don't know if we wanted to get more clarification from Jennifer about that.
Yes. Jennifer Blaze, you mentioned in chat that you have a similar scale to the one that Dr. McNicoll was discussing, and you asked if we could share it. Are you referring to the pain scale? Yes.
Yes.
I see you in chat that you said yes. Yes. So we can share a link to access that pain scale for you to print out. Morgan will include that in there's a follow-up email that she'll be sending out Morgan will provide information about that after we finish questions and answers. Do we have any callers that have any questions?
One just came in through chat about whether they could share the slides with the DON, and yes, you can share these slides once you receive them. And again, I put the link in chat for the slides, but I will do it again just to make sure.
I don't see the link, Morgan, so if you can share that again.
Morgan, I think you sent it privately.
So we have a comment in chat from Kathy saying, remember, no other pain scales can be used for MDS. Are you referring to during the MDS assessment, when they're doing the pain assessment? Yes. On chat, you're saying yes. So during the pain assessment, yes, it's very prescriptive. You can only say what the MDS questions are. However, you can use that pain scale prior to the assessment so that when the pain assessment is being done, the resident will have already been educated on that scale. Do we have any other questions? It looks like we have a question from Jennifer in chat. Are hospice patients included in the weight loss quality measure? That's a good question. I actually don't have that answer right now. Do we have anyone on the line from the QIO that has that answer? Pam says that it's not an exclusion, so patients on hospice are in fact included on the weight loss quality measure.
That's my understanding as well. I think, though, from a surveyor standpoint, it's important to document expected weight loss with hospice patients. But I think, unfortunately, for now, there's no way to exclude. There is a way, but not chosen to include that way to exclude hospice patients. Which is not right, but that's my opinion. You know, another thing that we haven't talked about is that incontinence is a very difficult. I think that a lot of people struggle with incontinence, obviously, because our metrics are still very high, and people feel like they get frustrated with focusing on a metric that is obviously difficult to reduce, because if somebody's sphincter is gone, or they have dementia that has affected their ability to control their sphincter, they're no matter how much effort you put in, they're likely going to have an incontinence episode. So even if you reduce it from 6 episodes per day to 1 or 2 episodes per day, you still get hit. And even though you're doing the right thing and it's a good thing for the person, it's a problem. There's a question, Sarah and Morgan, about what if it's a prescribed weight loss to somebody who's obese, or and also you could also put in there people who have heart failure that you're trying to get rid of 10 pounds of excess weight. Or are there any exclusions for those? Do you know?
Pam, if you're still on the line, can you help answer the question? If there's a prescribed weight loss, does that count for the QM? All right, so there are 3 options on the MDS to answer. If yes, on the physician-prescribed weight loss, then they will not trigger. And Jennifer Blaze made a a great comment as well in chat to make sure that it's care planned. So if it is in your care plan and the MDS answers yes, that it was a physician-prescribed weight loss, then it will not trigger that QM. Do we have any other questions on the line, or anyone that has questions? You can ask them in chat. All right, so I'm going to pass it over to Morgan in a minute. If anyone else has any additional questions, please feel free to add it in chat before the end of the webinar. And please join us for the follow-up webinar on February 9th, and you can ask questions then as well. So thank you all for the great questions. I have a few last announcements before we end today's webinar. You will receive a follow-up email with a link to a brief survey about today's webinar. We ask that you please complete it. This is very important. Your feedback can help us improve these sessions and provide you with meaningful programs. Also, within the next few business days, we will send out an email to everyone that contains links to both today's presentation and a recording of this webinar. That will also include a link to access that pain scale that we were talking about earlier. And don't forget to register for part 2 of this webinar on February 9th. We will have nursing home teams who will be sharing their best practices related to the topics of today's webinar, and there will be more time for you to ask your questions, including any questions that you have from today's webinar and chat that we haven't been able to get to. Thank you again for attending. Yes.
I think it might be useful, since there are lots of questions about exclusion and inclusion, to go over that briefly at the next session.
I think that's a great idea. We can put together some slides and talk more about the quality measures that we discussed today and how the MDS triggers those quality measures. I think that's a great idea. So thank you all again for attending. Morgan has a few closing remarks before we end today's call. Morgan, I'm going to pass it over to you.
Yeah, as you can see on this last slide, we just wanted to make you all aware that we are on social media now, so you can follow us on Facebook and LinkedIn, and then all of our webinar recordings are also now on YouTube. So be sure to check out the New England QIN-QIO on social media. And thank you, everyone. Thank you, Dr. McNicoll, for a great presentation, and we look forward to seeing you all on February 9th.
Bye, everyone.
Bye. Thank you, Lynn.
You're welcome.
Thank you all.
The reader has disconnected. The conference will be terminated in 5 minutes.